Assalamu alaikum everyone and good morning. Welcome to the PSA Karachi online lecture series. I'm your host for today, Dr. Abdullah Nisar, fellow from Ahsan University Hospital. Today we have Dr. Khalid Ahsan with us. Dr. Ahsan is currently working as assistant professor at the Department of Anesthesiology, Ahsan University Hospital, Karachi. Apart from anesthesia, Dr. Khalid has also completed cardiac anesthesia fellowship at AKU and is a member of AKU Neuro Anesthesia faculty group. He is among the pioneers who started Awake Not Me in Pakistan, and he will be talking on anesthesia for deep brain stimulation. I request you all to please turn your mics off and to write your queries and questions in the chat box section during the lecture, which will be answered at the end of the session. Dr. Khalid, please.
Thank you very much, Dr. Abdullah. Assalamu alaikum, everyone. Before starting, I disclose that I have no financial, professional, or personal interest that could improperly influence the content of my presentation. Abdullah, slides are not moving. Okay. The objectives of my presentation includes what is deep brain stimulation, indications, pathophysiology of Parkinson's disease and its treatment, anesthesia concerns, and intraoperative neurological monitoring, that is microelectrode recordings and macro stimulation. So what is deep brain stimulation? Deep brain stimulation is used for the treatment of patients with neurological disorders who have an alteration of function such as movement disorders and other chronic illnesses. The insertion of deep brain stimulator is a minimally invasive procedure that includes the placement of electrodes into deep brain structures, for example, subthalamic nucleus and globus pallidus, for microelectric recordings and intraoperative clinical testing, that is macro stimulation, and connection to an implanted pacemaker. The indications of deep brain stimulation includes Parkinson's disease, essential tremors, dystonia, obsessive compulsive disorder, chronic pain, and Alzheimer's disease. Before discussing deep brain stimulation and Parkinson's disease pathophysiology, I would briefly discuss some points regarding basal ganglia, because basal ganglia is the main region that that have contained nuclei that has to be stimulated during deep brain stimulation. So the basal ganglia are a group of subcortical nuclei that regulate voluntary and subconscious movements. The components of the basal ganglia includes corpus striatum. Corpus striatum is further divided into globus pallidus. It regulates voluntary movements. Caudate nucleus, it forms the lateral wall of lateral ventricles. Putamen, it primarily involved in motor pathways, and lentiform nucleus. Then comes some subthalamic nucleus. It plays a key role in indirect pathways of basal ganglia. Then comes substantia nigra, which is the main part that is involved in Parkinson's disease. It is the part of brain involved in dopamine production and motor control, primarily implicated in Parkinson's disease, that I have stated earlier. Then comes thalamus. It acts as a relay station, transmitting sensory and motor signals to cerebral cortex. It also plays a role in regulating consciousness, sleep, and alertness. So in this diagram, you will see the normal motor control pathway, showing on the left side corpus striatum and nucleus is found in the basal ganglia, that is external globus pallidus, internal globus pallidus, subthalamic nucleus, and on the right side you will see the thalamic nuclei as well. So these are the targets for deep brain stimulation insertion, showing caudate nucleus, globus pallidus external and internal, subthalamic nucleus, substantia nigra, and ventral intermediate nucleus of the thalamus. So briefly discussing about Parkinson's disease. Parkinson's disease is a progressive neurodegenerative disorder characterized by the loss of dopamine producing neurons, leading to motor symptoms such as tremors, rigidity, and bradykinesia. Bradykinesia is a slowness of movement in speed as movements are continued. So, pathophysiology of the Parkinsonism includes loss of dopamine producing neurons, that is, generation of the neurons in the substantia nigra, reducing dopamine levels, leads to impaired basal ganglia function, that is, disruption in motor control, leading to tremors, rigidity, bradykinesia, and posture instability. Then comes the Lewy body formation. In neurons, abnormal protein clumps alpha-synuclein accumulates, causing further neurological dysfunction and contributing to motor and non-motor symptoms. The management of the Parkinson disease involved a combination of pharmacological, and non-pharmacological approaches. The medication includes levodopa. It converts to dopamine in the brain to improve motor functions. I highlight levodopa. Levodopa cannot be given alone. It's always given with carbidopa, which is decarboxylase inhibitors. Carbidopa actually prevents the breakdown of levodopa before it reaches the brain. Then comes dopamine agonists. They mimic dopamine effects in the brain, for example, ropinirole. Then comes monoamine oxidase B inhibitors. They prevent the breakdown of dopamine, for example, salicylic. Then comes catechol or methyltransferase inhibitors. They enhance the effectiveness of levodopa, for example, tolcapine. And then comes anticholinergics. They help in managing tremors, for example, benztropine. So non-pharmacological approaches includes physical therapy, improves mobility, balance, and flexibility. Speech therapy addresses speech and swelling difficulties. Occupational therapy helps with daily living activities. Then come the surgical options, that is deep brain stimulation, where implanted pulse generator devices to regulate the abnormal brain activity. I will discuss in detail later on. Then comes the lifestyle modifications, exercise, a balanced diet, and psychological support to improve quality of life. So before discussing anesthesia concerns of deep brain stimulation, I will briefly discuss what are the surgical steps in deep brain stimulation procedure. Like any surgical procedure, pre-operative preparation is the cornerstone of every surgery. So it includes patient selection and pre-operative imaging. When we select, when the neurophysician and neurosurgeon select the patient for deep brain stimulation, they actually select the patient who fulfill the criteria for deep brain stimulation, and at that moment on admission, they use MRI scan on the day of admission. So patient selection, thorough evaluation by a multidisciplinary team, which includes neurologists, neurosurgeons, psychiatrists, neuroanesthetists. Criteria include medication, refractory symptoms, good cognitive function, and absence of severe comorbidities. This is the criteria to select the patient for deep brain stimulation procedure. Then comes imaging. As I've stated earlier, before the deep brain stimulation procedure, when the patient admitted, the neurophysician and the neurosurgeon team has taken an MRI scan to identify target brain regions, which is the hallmark of brain stimulation includes subthalamic nucleus for Parkinson's disease, ventral intermediate nucleus of the thalamus for essential tremor, and globus pallidus internus for dystonia. So initially, MRI will be done to localize the area of brain that needs to be stimulated. Then on the day of surgery, patient moves to CT scan where stereotactic frame placement has taken place. A stereotactic head frame, which is also called Leskill, is fixed to the patient's skull after giving a local anesthesia by the neurosurgeon. Then imaging CT is repeated. Initially, on the day of admission, MRI has been taken. Then on the day of surgery, CT scan has been done to fuse preoperative images with real-time coordinates. Then navigation on CT is merged with the MRI scan initially taken on the day of admission, and using this, the coordinates of the electrodes insertion are determined. Patient is then taken into OR and position spine and neck kept neutral. So after the patient has been taken on the operation table, patient fixed in position and G frame connected to the Leskill frame, that is a stereotactic head frame, following which the coordinates of the electrode insertion used to determine the point of burr hole. After this, electrodes are inserted into the pre-selected brain targets through a small burr hole incision after giving local anesthetics in the skull. So after the insertion of electrodes, electrode recording has to be done through these electrodes used to measure electrical activity in a target region and refine the location of electrode placement by mapping with different regions of basal ganglia. Then comes the neurological testing, macrostimulation. After micro electrode recording, the another phase which has come with, which is called macrostimulation, in which in this state the patient is asked to perform tasks, for example head movements, speech, to confirm optimal placement of the electrodes. Multiple test stimulations are performed to optimize therapeutic benefits and minimize side effects. In short, macro stimulation is performed after micro electrode recording to confirm functional accuracy of the electrode placement by stimulating the target area and assessing the clinical and side effects profile. Then comes the pulse generator placement. After electrode placement, a pulse generator battery pack is implanted subcutaneously, typically in the chest or abdomen. In our setup, it is inserted below the clavicle, and this procedure should be done under general anesthesia. The electrode are connected to the generator via extension wires tunneled under the skin. Then comes programming and adjustment. After surgery, the pulse generator is programmed to deliver electrical impulses at specific frequencies, amplitudes, and pulse widths tailored to the patient. So multiple sessions are required to fine-tune settings in regular follow-up in clinics. Then I will show some diagrams. This is the Leskill flame, which is attached by the neurosurgeon in the CT scan suit. A neurosurgeon is applying the Leskill frame in the CT scan suit. In the OR, this G frame is attached to the Laskell frame, that is stereotactic frame. In the OR burr hole, before burr hole, local anesthetic should be given before inserting the electrodes. Neurosurgeon is passing the electrodes through the burr hole. Then comes the microelectrode recording. This is microelectrode recording on a computer software. This is the microelectrode recording on the basal ganglion nuclear regions. Then comes marking for battery. So anesthesia concerns in deep brain stimulation. First comes the preoperative assessment. This needs preoperative psychiatric counseling and patient preparation like any other awake neurosurgical technique. Anesthesia-related concerns of Parkinson's disease, associated medical therapy, and principles of conscious sedation needs to be addressed in the pre-op clinic. Patient with cognitive dysfunction or severe anxiety should not be selected for awake PBS. Rather, they are selected for general anesthesia. Choice of anesthesia. So we have two choices. One is sleep, awake sleep technique versus a sleep TPS. In sleep awake sleep technique, routine ASA monitoring should be done in all patients coming to OR after Laskell frame attachment in CT scan. The patient is placed in OR table and Laskell frame is attached to G frame like I've stated earlier. After monitoring, conscious sedation was employed using propofol 1 to 3 milligram per kg per hour or dexmedetomidine 0.1 to 1 microgram per kg per hour. Depth of sedation was monitored using BIS and keep between 70 to 85. The most challenging part is initial phase of surgery where patients require conscious sedation. This sedative state is required for bilateral bulbar insertion of stimulating electrodes. After this, patient awakening is required during microelectrode recordings and macrostimulation. So for this recording of microelectrode recordings and microstimulation, centrally acting alpha-2 receptor mediated sedation and analgesia without anesthetic deprivation makes dexmedetomidine a preferred agent for the conscious sedation. So collaborative sleep induction pattern of dexmedetomidine allows better recovery profile and responsiveness after discontinuation of infusion of dexmedetomidine. So after microelectrode recordings and macrostimulation, the burr hole is closed, and the next step is general anesthesia with supraglottic airway device or endotracheal tube for replacement of implantable pulse generator. At the end of the procedure, dexamethasone and ambrisentan should be given. And after fulfilling the criteria of extubation, patient extubated in the operation in the OR. So in the OR, we have got severe challenges. Adverse effects are airway-related anxiety, vomiting, seizures. There is a challenge access to airway due to Laskell frame placement in case of airway compromise. So we use in our setup dexmedetomidine instead of propofol. So effect of anesthetics on microelectrode recordings and macrostimulation. In this regard, anesthetic agents should not interfere with microelectrode recordings and neural mapping. Local anesthetics, for example, lidocaine, it has no impact on microelectrode recordings. Propofol suppresses the microelectrode recordings, therefore should be avoided during localization. Volatile agents, sevoflurane reduces signal quality at high doses. Dexmedetomidine, it has minimal effect on microelectrode recordings and macrostimulation, useful for light sedation. Fentanyl have minimal effect on microelectrode recording in low doses. In fact, we use fentanyl at low doses to combat rescue anesthesia when needed in the intraoperative period. This is a typical microelectrode recording during mapping of the globus pallidus internus neurons. Changes in neuronal firing are shown as electrode travels from globus pallidus externus to globus pallidus internus. Movement-related flexion and extension changes in neuronal filings are also shown in the figure. So in conclusion, anesthesia and deep brain stimulation requires a balance of safety, comfort, and precision. ASA, sleep awake, sleep and GA approaches depends on the patient factors and surgical goals. Multidisciplinary teamwork is crucial for optimal outcomes. So I show some more diagrams. This is a classical diagram of a Leskill frame attached to G frame. Deep brain stimulation. This diagram shows anesthesia aspect from our side. We are using conscious sedation. Another diagram showing anesthesia machine on the one side and the surgical team on the other side. This is a microelectrode recording on a computer software. Burr hole has been done and the patient is ready for GA. So I want to show this is a publication 5 years back where we it's a retrospective review of 8 cases from a tertiary care center of Pakistan. We have reported 8 cases anesthesia management of a patient doing deep brain stimulation. Thank you very much.
Thank you very much, Dr. Khalid. The forum is open for the participants to ask any question, and if they wish, they can also choose to write their queries in the chat box. I believe there are no further questions from any participants, or if any anesthesiologist wishes to provide their feedback with regards to deep brain stimulation or any comment, that would be really appreciable.
Assalamu alaikum. I have a question. डेक्समेडेटोमिडीन देने से जो कार्डिक चेंजेस आएंगे हमारे, उनको हम कैसे कॉम्बैट करेंगे इसमें? मतलब व्हाट शुड वी यूज?
Actually, we use a low dose, and we have seen there are no hemodynamic stability at the cardiac heart rate जो आपको कम नजर आ रहा होता है, वो अमूमन उस वक्त देखा गया है जब हम बोलस डोज देती हैं डेक्समेडेटोमिडीन की. When we start infusion at a very low dose, so hemodynamic stability regarding related to डिक्रीज हार्ट रेट एंड हाइपरटेंशन वो हमें देखने में नहीं मिलती।
ओके, और जो सर्जरी है इससे कोई कार्डियोवास्कुलर चेंजेस आते हैं, मतलब जब हम डीप ब्रेन स्टिमुलेशन एज सच कर रहे होते हैं, सर्जन जब वो कर रहा है, जब
हाँ,
आप जो हमने
उसमें ये है कि ना, अगर हमने कॉन्शियस सेडेशन अच्छी दी हुई है और डेक्समेटाडोमिन की डोज है, पेशेंट सो रहा है, तो इतना ज़्यादा फर्क नहीं पड़ता। कभी कभी जो है ना, हमें रेस्क्यू एनास्थीसिया देना पड़ता है इन द फॉर्म ऑफ फेंटनिल। तो हम ना लो
और
डोज में
एक और
फेंटनिल
क्वेश्चन था
जी।
कि आपने बताया स्लीप अवेक स्लीप वाला है, तो इसमें हमने इंट्यूबेट कर देना है पेशेंट को, मतलब जनरल एनेस्थीसिया दिया हुआ है, बैग मास्क वेंटिलेशन है कि इंट्यूबेटेड होगा?
अच्छा, इसमें जो शुरू के 2 फेजेस है ना, इसमें पेशेंट
Dr.
को
Ramshan, Dr. Khalid, sorry
ओके
for interrupting, but I would request you guys if you can uh, have the conversation in English so that the
ओके।
participants who are
तो
from
फर्स्ट
outside Pakistan,
स्टेज,
they can also help.
डॉक्टर रमशा, फर्st stage is sleep, in which we
Okay.
employed conscious sedation. In the second stage, we awake the patients, during which microelectrical recordings and macrostimulation take place. When this has
Okay.
been done and burr hole has been closed, then comes the placement of pulse generator, implantable pulse generator, which needs which needs actually general anesthesia, in which Laskell frame has been removed, and then uh, 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 supraglottic airway device or endotracheal tube has been applied in the last stage.
Okay. Thank you, sir. Thank you so much.
Thank you.
Dr. Abdullah.
Ji, Dr.
Uh,
Faraz,
so I just want to comment on Dr. Ramsha's question. I think Dr. Khalid Hassan has already replied that, but I just want to add few comments. So regarding dexmedetomidine, as Dr. Khalid Hassan was saying, so at the therapeutic doses, without giving the bolus, which is around 0.5, mics per kg per body weight within a period of 15 to 30 minutes. So usually at that time, you should be anticipating that you'll get some sort of hemodynamic response. But as Dr. Khalid was saying, so it's not a problem at the therapeutic doses for conscious sedation. So yes, if you'll go up with the sedation, so you might end up in having bradycardia. So that bradycardia is quite manageable with the low doses of either glycopyrrolate and atropine without increasing the blood pressure. So it's in my clinical practice. So the second question was regarding the hemodynamic response. So as Khalid was saying, so at times it might be associated with the pain, which is usually not a problem unless your patient got agitated or having some sort of, emotional instability in the operative phase. But yes, at times it has to do something with the, electrode placement, or has to do something with some sort of, adverse neurological consequences which are related to the, which is, the catheter insertion. So in our setup, so the surgeon is coming from the Turkey, and he's asking specifically for having RTL line to overcome or to look at those kind of hemodynamic changes intraoperatively.
Thank you,
thank
Dr.
you very much,
Faraz.
Dr. Faraz. For the participants, Dr. Faraz too is a practicing neuroanesthesiologist at AKU and has been a core part of the brain stimulation anesthesia along with awake rhinotomy. So it was nice to hear from you, Dr. Faraz. Another question from Dr. Shahid Dar is if there are any special concerns regarding anti-Parkinsonism and medication history, Dr. Khalid.
Yeah. So we usually neurophysician omit and we in the pre-op assessment we usually addressed omitting the overnight dose of Parkinson's disease.
All right, I hope that had been the answer for you, Dr. Shahid. Any other questions from the participants to be entertained? The forum is still open for you all.
Assalamu alaikum, Professor Durrani from DG Khan. An
Yes,
excellent
Assalamu alaikum,
presentation. मेरी क्वेश्चन ये है सर कि इस लो डोज प्रोपोफॉल में 1 to 2 मिलीग्राम पर केजी पर आवर और 0.1 माइक्रोग्राम पर केजी पर आवर डेक्सामेथासोन के साथ एडिक्वेट सेडेशन मिल जाती है जिसपे वो प्रोसीजर कर सके?
नो, हम 0.1 पे नहीं देते। हमने आपको बताया कि इट्स रेंजेस बिटवीन 0.1 to 1 माइक्रोग्राम पर केजी पर आवर ना।
जी जी।
तो वी यूजुअली गिव डेक्समेथासोन इन डोज ऑफ 0.8 to 1 माइक्रोग्राम पर केजी पर आवर, उस पे मिल जाती है
विदाउट एनी इनिशियल बोलस।
without any initial bolus, because we will give time. We will give time to patient. The patient, when the patient come in the OR, we actually start it before anything. हम start कर देते हैं, initially start कर देते हैं इसको।
तो
तो
कितनी देर
10 से 15 मिनट में इफेक्ट आ जाता है।
ठीक, राइट सर, थैंक यू वेरी मच।
And other important thing, I just want to comment on the professor's comments. So it's very important for us to understand a kind of thing which is going on, after for the insertion of catheter or the burr hole. It's not a that much painful stimulus, so can easily be done under local anesthesia. So it's not a kind of stimulus where we are expecting a lot of pain, and on the top of having Presidex infusion, so you can start your case with a bit of fentanyl and paracetamol also.
Fentanyl 1 microgram per kg or 5 microgram per kg?
Yeah. Oh, yes, it's around one. There is no need of giving too much of those. Yeah. So you are not dealing with a kind of stimulus where you will be anticipating, hemodynamic response related to that.
Thank you, Dr. Faraz, and thank you, Dr. Khalid. I believe that would be it from today's session. I would ask the participants to fill up the evaluation form, after which the certificates would be emailed to you along with the video link recording of this session from the YouTube. Thank you very much.